Hello, everyone. Good morning. Thank you for inviting me to talk and discuss on epicardial echocardiogram. And again, I'm Shanthi Narasimhan. I am from University of Minnesota, pediatric cardiologist. The objective here is mainly to discuss about a comprehensive epicardial echocardiogram examination. And I'll be discussing my cases that our cases were done at the University of Minnesota. I have no financial disclosures. Let's start with the utility of intraoperative echocardiography has become an invaluable tool for monitoring cardiac performance and diagnosing pathology in patients undergoing cardiac surgery. The surgeon continues to appreciate its potential application as an invaluable tool. Perioperative echocardiogram has been shown to influence surgical management in as many as 50% of the cases based on the American Society of Echocardiography literature. TE continues to provide valuable information during the operating room. We are not substituting TE. Epicardial echo acts as a complement in the operating room. TE imaging of the distal ascending aorta and the aortic arch and other few structures may be impaired by the interposition of the trachea and mainstem bronchus. TE can provide, the advantages of TE is that it provides continuous monitoring and does not require interruption of the surgical procedure. It has very minimal limitations. But however, the other imaging approaches to conduct a comprehensive perioperative echo exam should also be familiarized. Epicardial echocardiography is a useful approach to intraoperative imaging for small patients and in those with contraindication to TE, like those with the tracheoesophageal fistula or some type of esophageal varices. And if you have some issues with the hemodynamic instability as you pass through the TE probe, I think epicardial will act as a complement. Epicardial echo examination can be performed very effectively and safely. Epicardial imaging can provide optimal image resolution and may offer a better windows for branch pulmonary arteries, proximal descending aorta, and coronary arteries. And I have few examples of them. What are the training guidelines requirement? It's a unique imaging which requires a collaborative effort with the cardiac surgical team to allow the echo team to have a direct access to the epicardial surface within the operating room field. So at least a minimum of 25 epicardial exam is recommended per year. And when you're training a fellow in epicardial echocardiogram, at least they need to have 25 of them with 5 at least minimum direct supervision. So epicardial echocardiogram, what type of transducers would you pick? Anything should be operated between 5 to 12 megahertz frequency range. Higher frequency transducer have the advantage of higher image resolution, but because of the linear relationship between the transducer frequency and signal attenuation, may not image more distant structures adequately. For epi-aortic scanning, high-resolution transducer with an imaging frequency of more than 7 megahertz and an approximately small footprint should be used. The choice between linear and phased array transducer is determined by the preference and the availability. Linear array transducer provides superb proximal image resolution, but not suitable for epicardial imaging because of the limited image width and depth. A pediatric or a neonatal phased array transducer is suitable for epicardial imaging and with sufficient standoff distance from the anterior surface of the aorta and enables imaging of the entire ascending aorta in a long axis within one image plane. How do you handle the transducer? How do you clean it? Transducer must first be cleaned, placed in a sterile sheet before its use in the surgical field. This can be accomplished by having the surgeon or a scrub nurse hold up a sterile sheet containing the ultrasound gel so that the anesthesiologist can feed the non-sterile transducer into the sheet. Once introduced into the sterile field, the surgeon or the cardiology team manipulates the transducer while the anesthesiology team or your fellows can adjust the setting on the machine. Epicardial, I use a 12 megahertz transducer. It's very small, cumbersome, and it's very efficient in the pediatric patient. The probe is again placed in a sterile sheet along with the acoustic gel to optimize the transmission, and a warm sterile saline can be poured into the mediastinal cavity to further enhance acoustic transmission. These are all images obtained in our operating room at the University of Minnesota. This is a linear array transducer, which is placed in a sterile sheet and is placed directly on top of what we are showing is in the ascending aorta. This was a paper that I was presenting to look at the epi-aortic data set, looking at the coronary artery imaging. And this one is actually a porcine anatomical specimen. We are trying to show the transducer where it is being placed to actually acquire the entire right side of the heart, the tricuspid valve, RV outflow tract, and you can see the pulmonary valve and the aorta with the 3 cusps. This is how we train our fellows. And then the transducer is directly placed on the aortic root, as we can see here, so that we can visualize the left ventricular outflow tract, the aortic valve, and the ascending aorta. The next is the transducer is placed right at the level of the interventricular septum. It's just a little bit more angled posteriorly to actually visualize both the short axis view of the left ventricle, the RV outflow tract. You can actually see the trileaflet tricuspid valve, as well as the anterior and the mitral leaflet. The next will be the transducer placement is more directed superiorly and anteriorly so that you can open up the left ventricular outflow tract as like a parasternal long axis view. And there's the next few slides will be an examples that we had acquired in the operating room to demonstrate the surgical team if there is any residual lesions, or we have to go back on bypass to fix the branch pulmonary arteries, and how good the operation has been. So here, this is again a porcine model where the transducer is placed right on top of the RV outflow tract. And here's an example of a conduit placement. We wanted to see the competency first of the valve conduit. This is a pulmonary valve conduit that is placed with the branch pulmonary artery obstruction. Then just to give you guys an example, this is a transesophageal echocardiogram. We wanted to see if there's a residual VSD. How does the RV outflow tract appear? There is a limitation with the image resolution. The same exact view that we had obtained here demonstrates this is an epicardial echo showing the mitral valve, left atrium, mitral valve, left ventricle. Here is the VSD patch, LV outflow tract. Appears to be nicely widely patent. LV function looks good. And if you add a color flow Doppler, we should be able to demonstrate if there is any significant residual lesion or not. The next image will be, this is a tetralogy of fellow patient. Recently, we had operated on about 2 weeks ago, where the infant was very, very small. If we were unable to place a transesophageal probe, it's about 2 kilogram baby who had Hirschsprung disease and had a lot of abdominal issues, but at the same time having TET spell. We had to place a Belloc-Taussig shunt, and here is an example of an RV outflow tract. This is an epicardial echocardiogram demonstrating significant RV outflow tract as well as a branch pulmonary artery flow turbulency we can see. And this is a demonstration of a shunt. We had used a saphenous vein graft to demonstrate the flow to the branch pulmonary arteries from the innominate, the base of the innominate artery. And this is another example. The first time I showed you guys the slides, this is a tetralogy fellow patient with pulmonary atresia and unifocalized segment. And it's a redo operation for the branch pulmonary artery obstruction. Again, the pulmonary valve is very competent. The proximal portion of the condo appears to be widely patent. However, the distal end of the anastomosis to the proximal branch pulmonary arteries are narrowed with the systemic right heart pressure. And this is demonstrated by the flow patterns in the RPA flow turbulency. Starting at the proximal region, you can see both RPA and LPA. And this is another view demonstrating the pulmonary valve competency. So the proximal portion of the condo appears to be fine. It's the distal anastomosis that appears to be narrowed. And this is post-surgical demonstration of the branch pulmonary arteries, because the transesophageal imaging was very limited. We wanted to make sure absolutely certain that the branch pulmonary arteries are widely patent. Here is the right pulmonary artery that after plasty, this is the left pulmonary artery, which appears to be a little smaller. However, it's widely patent. And we can demonstrate the flow. Again, a competent pulmonary valve. Flow patterns in the branch pulmonary arteries appears to be widely open. The next few slides, again, this is another patient who underwent unifocalization. We wanted to make sure that the portion of that, the collateral were augmented into the pulmonary arteries, into the condo itself. And here is the demonstration of the right upper lobe branch, which is being documented, appears to be widely patent. And we wanted to show, this is another patient we wanted to show, it's again a tetralogy of fellow patient with the branch pulmonary artery obstruction, especially the RPA. We wanted to see all the way to the hilum, and here is a demonstration of the right pulmonary artery appears to be widely patent. And it's very useful for the surgeon to take a look at it, and if we need to go back and redo or patch augment the branch pulmonary arteries. And here is the flow pattern in the RPA, which appears to be very laminar. The next set of slides will show you what is the other areas of focus. Is my interest has always been in coronary artery anatomy. And again, this was another tetralogy fellow patient, very small. We were unable to do a complete repair in the newborn period. However, by transthoracic echocardiogram, there was a concern whether there's a dual LAD supply. And here you go. This is an epicardial echocardiogram. This is the right sinus giving rise to the right coronary artery. And this is the prominent, this is right anterior descending. However, that does not cross the RV outflow tract. We demonstrated one on the surgical field, and as well as with the epi-aortic imaging, you can see the coronary flows. This adds as a complement to our team saying we can go back to offer a transannular patch later on. And again, this kid was very, very small, was a premature baby having TET spell. We were unable to go for a full repair and offered a shunt procedure. And here is an example of the image resolution when you do epicardial imaging, demonstrating the coronary artery 2D along the course. And as I said, I had utilized a linear array transducer to demonstrate coronary artery patterns or coronary artery origins. And this is the right coronary artery flows. And this was a paper that was published recently on the utilization of epi-aortic imaging using a linear array transducer. This patient actually had the proximal left coronary artery was very stenotic, had a collateralization through the right coronary artery. You can see there is narrowing of the proximal left, and there is a turbulency in the flow in the proximal coronary artery, which we were unable to show by transesophageal echocardiogram or by transthoracic echocardiogram. Again, this demonstrates the coronary arteries, the right coronary artery, which appears to be widely patent. And again, the flow during diastole can be well seen by epicardial echocardiogram. The next set of data set that I'm going to share is transposition of the great arteries after the Lecomte maneuver arterial switch. We know that post these pulmonary arteries are quite stretched, and there is proximal branch pulmonary artery narrowing, which we can easily show the Lecomte when the PAs are stretched. They are very small and causing obstruction to the RV outflow tract, causing systemic pressures. And the surgeon, we can show to the surgeon that it has to be patch augmented. Where does it need to be patch augmented? Exact locations can also be demonstrated. And here's a post-procedure appears to be widely patent. And again, this was a demonstrating the proximal stretching and narrowing. And this image shows you that it appears to be widely patent after post-surgery. Again, this is another image to show RPA appears to be widely patent after post-surgical repair. This is another view. The next set is where we had another small infant preemie with critical coarctation of aorta, but the aortic valve was very, very unicuspid appearance, and we were not sure if we repair the coarct, will there be any aortic stenosis, any LV outflow tract obstruction. And so we wanted to show the aortic valve opening and closure, which behaves like a unicuspid valve. And this is pre-procedure, where very limited mobility of the aortic valve was seen, and the flow is being demonstrated without any obstruction. Again, showing the flow patterns appear to be okay in the ascending aorta. And this was again after the repair. We wanted to show after the coarctation repair, we placed an epicardial echo to demonstrate that there is no obstruction to the aortic valve. And this was the patient with coarctation of aorta. We showed the aortic arch with the flow turbulency, and this was after surgery. We demonstrated the aortic arch appears to be unobstructed. At the same time, there is no evidence of any left ventricular outflow obstruction. Epicardial echo can also be utilized during when you're assessing a single ventricle. This was a patient with a corkscrew type of aortic arch reconstruction. We wanted to make sure why the single ventricle function has deteriorated, whether this is a DKS issue. We're showing the native and the reconstructed aorta appears to be nicely widely patent, and by color flow imaging looks fine. And the neo-aortic valve is very competent valve. And you can start seeing the corkscrew, the aortic arch, and which was causing significant single ventricle function deterioration. And this is post-procedure. However, we are not able to reconstruct as a normal arch pattern. This is very augmented, a very dilated aneurysmal aortic arch. Again, this is the corkscrew arch, and the one after that was post-procedure. I have very special interest in the computational fluid model. You can see this was a single ventricle arch, which very tortuous, and the energy loss is quite high, and the ventricle has to work hard compared to a normal aortic arch flow pattern. So we are starting to look at more research or evidence-based data about the energy consumption in terms of a bicuspid aortic valve. This was obtained from one of the adult studies comparing the bicuspid aortic valve, where there is a higher energy loss associated with the bicuspid aortic valve and a dilated ascending aortic geometry. that are not accessible by current echocardiography technique. These findings indicate that there is a kinetic energy may provide complementary information to echo, helping to distinguish within the heterogeneous population of patients with moderate to severe AS, which I'm applying it to single ventricle patients to see if there is a lot of loss of kinetic energy with the slightly different aortic arch anatomy. And so in conclusion, the epicardial echo data clearly has shown, this is a literature that I'm presenting, that it is very useful in certain situations, especially when you wanted to make sure there is no residual lesions intraoperatively that you can easily visualize by epicardial, limited by the TE. So it is epicardial echo is accurate, it's economical, safe imaging modality that can be performed routinely in all patients undergoing corrective surgery, and is especially useful for pathologies requiring evaluation of pulmonary arteries, branches, coronary artery, as well as some type of VSDs too. It requires team effort. Thank you for your time. I really appreciate you giving me the opportunity to talk in a very big national conference. Thank you.